Extract 1. Questions 1 to 12.
You hear a pulmonologist talking to a patient called Pam Herbert. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Now, Pam, I see you've been referred to me by your GP, and I've got your notes here, but perhaps we could start by you telling me, in your own words, about the symptoms you've been having, any treatment you've had, how that's gone, and anything else you feel I should know.
Well, to be honest, I've just been feeling absolutely terrible. I've got this awful cough that just won't go away no matter what I do, and I keep coughing up all this stuff. It's sort of brown. It looks horrible. And the cough's much worse at night, so of course that's been interfering with my sleep.
Okay.
So I'm what you would probably call fatigued all the time. I feel like I have to try to get through every day rather than live it. It doesn't help that, weirdly, I'm just not hungry at the moment either. I'm really off my food, and that's led to me losing weight, which is probably a good thing. But it's not helping with my energy levels.
Are you otherwise well? I mean, have you noticed any other changes in your health?
Well, one quite big thing is that I'm finding it difficult to walk very far. I can manage short distances, but if it's going to take longer than 10 minutes, you can forget it.
Okay.
And then just a few little aches and pains, but they can be annoying. I've noticed that my rib cage feels really painful when I've been laughing. It's agony. And recently I've been getting this sort of feeling down my right arm. It's like a tingling feeling, I suppose. I can't use my arm at all when it's like that.
And how long would you say that all this has been going on?
Oh, quite a few months. It all started when I had flu back in January, so about 9 months ago, I suppose. That quickly turned into glandular fever, and I was ill for a good 6 weeks with that. I don't even feel like I've fully recovered now. And then I've had 1 or 2 quite nasty chest infections lately, and they've been difficult to shift.
Well, that's certainly something we can look into. I see you're a smoker. How long have you smoked, Pam?
Well, in total, I was working this out with my husband the other day, it's about 35 years. I know that sounds bad, but it hasn't been constant. I have quit quite a few times, and it's just that I always go back to it. I've always suffered from insomnia, on and off anyway, and giving up always makes that so bad. It means I can't function properly because I'm so sleep deprived. One of the reasons I'd like to give up cigarettes forever, though, is to get my sense of smell back. You know, that went about 10 years ago. It's amazing how much you miss it. I mean, I didn't realise how much pleasure it gave me. It affects so many different aspects of your life.
And as far as current medication is concerned?
Well, for about 10 years now, I've been taking a statin, I don't remember what it's called.
Don't worry.
And I'm still using my salbutamol inhaler. I take that everywhere I go. I find I get out of breath so easily, and I do tend to panic. And I'm still on the antidepressants I was prescribed a year ago. They seem to be working really well, so I don't want to change anything there. It's all good, apart from the obvious worry and inconvenience with this cough and everything.
And any allergies?
Well, I never drink milk. It makes me throw up. And years ago, my GP diagnosed an intolerance, which came as quite a relief. And I don't know if it counts as an allergy, but hay fever always makes me really miserable. I literally can't go outside. I just stay indoors with the windows shut and take my medicine.
Extract 2, questions 13 to 24. You hear a doctor talking to a patient called Mrs. Breege. For questions 13 to 24, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, doctor. Good morning.
Good morning. May I know your problem?
Well, I have headache. The headache first began 2 months ago. I feel a sensation of pressure. The intensity is moderately severe, making regular activities difficult. I fear I am getting much closer to sinus congestion, or maybe photophobia.
What's your age?
42, doctor.
Do you drink or smoke?
Well, I do not smoke, but I drink regularly.
Tell me if any of your family members have any history of illness.
My father and brother have a history of migraine, doctor.
Is there any congestion in your chest or throat?
Yes, I have some sinus congestion.
Did you have any cardiovascular problems?
No, doctor.
Any gastrointestinal problems in the past or present?
No, doctor.
Are you taking any medications?
No, doctor.
Are you allergic to any medicine?
Yes, codeine.
Do you have any muscle cramps, joint pain, back pain, or limb pain?
No, doctor.
Do you have any musculoskeletal problems, or in the past?
No, doctor.
Well, the sense of smell of your cranial nerves was intact. Neck range of motion was normal in all directions. There was no evidence of cervical muscle spasm. No radicular symptoms were elicited by neck motions. Shoulder range of motion was bilaterally normal. There were no areas of tenderness. Tests of neurovascular compression were negative. There were no carotid brutes. Back range of motion was normal in all directions. Position and vibratory sense was normal. Your gait has no abnormal components. Tandem gait was performed normally. There is no edemia or significant varicosities. You have developed migraine without aura. I am going to describe therapeutic trial of Inderal 40 milligrams, half tablet twice a day for 1 week, then 1 tablet twice a day for the next week, and then for the third week, 1 tablet thrice a day. Continue these medications for 3 weeks and meet me again after 3 weeks.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. Now read the question.
Good evening, Mr. Jones. It's Jane, one of the SHOs that's on call this evening. I'm calling from Ward 4 about a patient called Stephen Smith. Yeah, he's a 45-year-old gentleman, 5 days post-lap coli. Looking at the op note, it looks like it was quite a difficult procedure that was converted to open due to a difficult dissection around the bile duct. I've reviewed him as he's had an increased abdominal pain over the last couple of days, and this hasn't really settled with increasing amounts of opiate analgesia. Well, he was admitted to the ward 5 days ago after his surgery. He's normally fit and well, doesn't take any regular medications, and doesn't have any allergies. Since he's been with us, he's had some regular simple analgesia such as paracetamol, and also this evening increased in amounts of morphine. He's on day 5 of a course of oral coamoxiclav. Looking at his bloods, his white cells and CRP are showing an upward trend over the past 3 days.
Question 26. Now read the question.
This is Mr. Gervais. He's a 79-year-old gentleman. He's been had general malaise over the past few months, increasingly short of breath over the past few weeks, was extremely short of breath today. 911 was called. When they arrived, he was tripoding, short of breath. His pulse ox on arrival was 69%. He bradyed down to a PEA arrest. They did 2 rounds of CPR, and there was a return of pulses in 8 minutes. And he was intubated in the field. He was brought into our hospital. Give you a little bit of history of Mr. Gervais. He has history of diabetes, hypertension. He had thyroid cancer back in 2006, which was his thyroid was removed, and also received a local radiation then. He has an allergy to penicillin. And he's currently on a hypothermia protocol post PEA arrest.
Question 27. Now read the question.
Margot, my shift is coming to a close and it's time for bedside report. This is your new nurse, Patty. She's a great nurse. I'm leaving you in very experienced hands. And this is Audrey, Margot's daughter.
Hi, nice to meet you both. I'm replacing Sandy and I'll be with you till 7 a.m.
We're going to start report now, so feel free to add any information or ask any questions. Margot Carley is a 56-year-old that came through the emergency department and admitted for pneumonia.
Okay, Margot, can you please state your full name and date of birth?
Sure, Margot Carley, 6/26 of 60.
Thank you.
Margot presented to the emergency department early this morning with difficulty breathing, cough, and chest pain. She had a room air oxygen saturation of 84%. She has a history of a recently treated pneumonia, and we are currently giving her IV antibiotics and IV steroids through a PICC line on her right side that was placed this morning.
Question 28. Now read the question.
So this is Mr. Gervais. He's a 79-year-old male with a history of thyroid carcinoma, originally diagnosed in 2006, where he had a thyroidectomy as well as ablation, which reoccurred in April of 2009 in his thyroid as well as his lung. Also has a history of diabetes, OSA, paroxysmal atrial fibrillation, hypertension, bladder cancer, status post of TERP, and BCG. Who came into the Wilmington ED early this morning, status post the PEA arrest at home. He, at home, had been complaining of worsening shortness of breath times 1 week. When they called EMS and they arrived at his house, he was noted to be in severe respiratory distress in the tripod position with an O2 sat of 68%.
Question 29. Now read the question.
So Mrs. Jones had surgery on her back. Today is her 3rd day post-op. She's doing excellent. She's getting up with 1 assist, utilizing a walker, ambulating to the bathroom, and Dr. Fandaka was her physician. Pain was pretty well controlled. Ranges up to a 7 at times, and taking 2 to 4 milligrams of dilaudid PO.
Okay. And you feel like your pain is getting well controlled with that dilaudid? Awesome.
The last dose I gave was at 3:30, and she only took 2 milligrams, so she can have more at any time if needed. Tolerating her diet well. Do have the IV fluids running. Let's take a look at the pump together.
Question 30. Now read the question.
All right. This is Mr. Eddie Smith and his daughter Amanda. Amanda brought Mr. Smith in through the ED earlier, and he presented with some right-sided weakness, and his speech was slightly slurred. He was admitted to us on a stroke care track, and he transferred up this morning. He has a history of diabetes and hypertension, and Amanda told me that he hasn't taken his blood pressure medications in about 2 weeks.
Yes, I picked up his medicines, but he wouldn't take them.
And I've already looked at those medicines, and his home med list is already on the chart, and it's been signed. He had a CT scan done before he arrived to the floor, and the results came back negative. And he just came back from MRI, and he has a CT angiogram ordered by his neurology consult, Dr. Elahi.
My CT was negative. Why did you run up 2 tests?
Well, even though your CT was negative, you still had to have the MRI because it's a more conclusive test, and it tells the doctor more about what's going on. It can show some things that the CT wouldn't show, so they would still order that test.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1. questions 31 to 36. You now have 90 seconds to read questions 31 to 36.
It's been estimated that around the world there are millions of people who are otherwise healthy, have never had a heart attack or stroke, are not at high risk of bowel cancer, yet who take aspirin on a daily basis, convinced that it's going to help them. Well, the evidence from the largest ever study in this area suggests not. A huge trial called ASPREE, involving healthy Australians and Americans aged over 70, given low-dose aspirin for 5 years, has found no benefits and some harms. The research was led by Professor John McNeill of the School of Public Health and Preventive Medicine at Monash University, who I spoke to before we went to air. Welcome to the Health Report, John.
Thank you, Norman.
It's pretty impressive, 3 papers in the New England Journal. What sparked this study? Because it was Australian motivated, even though it occurred in the United States as well.
I think we've been aware since the 1990s that there's an evidence gap, that many millions of people take aspirin every morning, and the evidence base, particularly for those who haven't had a heart attack or a stroke or have no other medical reason to be taking it, the evidence just isn't there.
So what did you do in this study?
We recruited 19,100 people from the United States and Australia. 16,700 were from Australia, and we followed them for an average of 4.6 years, and half of them took aspirin and half of them took placebo.
And what were you looking for? What were your endpoints?
Well, the endpoint here was disability-free survival, which is a measure of how long elderly people stay healthy.
But how did you measure that?
By measuring how long it took for people to remain healthy without having a permanent physical disability or developing dementia.
And what did you find?
Well, we found 3 things. Firstly, low-dose aspirin did not appear to increase survival.
Disability-free survival or survival?
Disability-free survival and survival. And it also didn't prevent heart attack or stroke. I think I should emphasise that this study was done in people who'd never had a heart attack or a stroke, because people who have routinely take aspirin under very strong evidence to prevent them having another one.
So we're talking about healthy people recruited who were over 70 on average, is that right?
That's right. The average age was 74.
What about cancer? A lot of people take aspirin to prevent cancer, and there is some randomised trial evidence that aspirin can prevent cancer.
Yes, this was a surprising finding in our study. There were numerically more people dying of cancer in the aspirin arm than in the placebo arm. This was a relatively small effect. It wasn't statistically significant once we adjusted for the multiple comparisons that we were making, and it hasn't been seen in other large clinical trials. So we're suspending judgment as to what its significance really means.
And what were the complications and the side effects?
Well, we had the usual side effect of bleeding. We took a lot of care over the measurement of bleeding because older people are more inclined to bleed, and aspirin enhances that effect. And we certainly had an increase in hemorrhage in the people taking aspirin.
Now, previous studies have suggested, and we had this on the Health Report, I think it was last year, suggesting that if there was a hemorrhage risk, it was early on and that settled down later.
We looked at this, but we couldn't find that. And according to our data, the risk of hemorrhage just kept going.
Now, we had a story not so long ago on the health report suggesting that the effect of aspirin, of low-dose aspirin, is actually only there in people who weigh 70 kilos or less. And that if you want to get an effect from aspirin, you should be on a higher dose, like 325 milligrams or even 600.
We've had a brief look at that, and we couldn't find that in our older people.
What about dementia?
Aspirin appeared to have no effect at all on dementia.
But 4 years is not a long time to develop dementia. I mean, did you measure cognitive decline?
Yes, we measured cognitive decline very carefully, and we haven't analysed all the data yet, but certainly the number of people who were diagnosed with dementia was the same on each arm. But that raises a very important issue, because we will be following the people who participated in a spree over the long term to see if there is a difference in incidence of dementia or cancer that appears later. And we know that there's been evidence that cancer preventive effect does take 4 or 5 years before it becomes evident. That's one of the reasons why we've been very keen for our spree participants throughout both countries to continue to be involved and let us follow them up.
Now, if you have hemorrhage or you have side effects like gastric upset or something like that from aspirin, the people who are taking the real thing might have dropped out more than people on the placebo. That could have affected the results?
We did a lot of testing of how many people were taking aspirin. We counted their pill bottles and so on, and we found that basically there was very good compliance with the medication on both arms of the study.
Could this be a phenomenon of, as we are getting older, we're actually not necessarily aging, we're actually living longer, younger, and we're getting less heart disease? Was this population too young, paradoxically, even though they were 75? Were they actually too young to get an effect? Because 75 is like the new 50, as they say.
That's an interesting question. We followed people whose commencement average age was 74 and whose final average age was nearly 79. So that's following people through a reasonably long period. We had a number of people who were over 80 years of age, and as far as we could tell, there wasn't a really big difference between the impact of aspirin at any of these ages.
So if somebody's taking aspirin now, they're entirely healthy, they've never had heart disease, they've not had bowel polyps, which is another reason why some people might take aspirin to prevent the polyps turning into cancer or new polyps emerging, and they're on aspirin, should they just stop?
Look, we're not recommending this at this point. People taking aspirin take it for 3 reasons. I mean, some, of course, as you said, have had a heart attack or a stroke or something similar in the past, and they should definitely be on aspirin because the evidence is strong. And then there's others who've been put on aspirin by their doctors for a range of other reasons, and they should continue as well, certainly not stop without getting advice from their doctor. But then there's the third category who may have just decided, they've read somewhere, they're perfectly healthy, they think it's a good idea. The results of a spree will lead these people to reconsider whether that's a good idea.
Just finally, do we know the numbers of people who are taking aspirin unnecessarily?
We know that it's much more common in the United States, where about 40%.
The date's wrong.
Extract 2. Questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
Here on the Health Report, we cover all sorts of research. The Mediterranean diet, what fat is right for you, how much salt is safe, diets to protect you from diabetes, early death, heart disease. So this next segment is actually a bit perturbing. We're being told that almost all this research is wrong. Yes, John Ioannidis is Professor of Medicine at Stanford University, and he says the scientific approach taken by nutritional researchers is nowhere near rigorous enough, and we have to go back to basics if we're to learn anything significant about how diets impact health.
Thank you for inviting me.
Now, we've had you on lots of times before, talking about various things and demolishing a few iconic areas of health and research. You're arguing that nutritional research needs radical reform. On what basis do you say that?
Well, there's clearly a factory of papers being produced in nutrition epidemiology in particular that don't meet very high standards of credibility. The type of research that is being done in nutritional epidemiology, it's not an issue that there's bad scientists involved in it. Maybe excellent scientists are involved in it, but the odds of getting it right are extremely small.
Let's look at that in a moment, but you quote in your paper some really bizarre conclusions that you might come to from if you've believed past nutritional research. Do you want to just tell us some of those bizarre findings and their relation to either longevity or shortened lifespan?
Most of these studies are not experimental, they're not randomized, they're just observing people who report what they eat, and they take that seriously, that this is reflecting exactly what they ate, which is one major assumption. Second, people take these behaviors and these numbers as causal, which means that they look at the numbers and they translate them to an effect of these nutrients or of these foods on mortality. And then they also make another assumption that these risks are applicable to the entire lifespan. So then, let's take a number like 15% relative risk reduction in mortality or 15% increase in survival, which is a typical number that comes out of these studies. And this is the number that is the summary of all the data, for example, on what is the benefit with eating 12 hazelnuts a day. If you translate that to a gain in survival, you take 80 years, you multiply that by 15%. This looks like a 12-year gain in survival just by eating 12 hazelnuts a day, or literally one hazelnut a day would give you one more year of life as a benefit. It's a ridiculous calculation. It is not so, of course. Even if you believe that one of these foods or one of these nutrients or a couple of them may be important, it's impossible to believe that every single food, every single nutrient will have such tremendous benefits or such tremendous risks.
So you get there because of there's multiple levels of unreliability. Is that what it is? That essentially the food diary is unreliable, they're not controlling for other factors such as education and other environmental factors properly, and they all conflate together to give you bizarre results? Is that what's going on?
Exactly. It's a problem at multiple levels. It's an extremely difficult field to study. And it doesn't mean that observational studies, that epidemiological studies get it wrong all the time. In many other fields, the problems are much more straightforward. For example, we know for sure that smoking is killing zillions of people. It will kill 1 billion people in the next century unless we do something. But the effect of smoking is huge. The risk increases 20-fold if someone is smoking for getting lung cancer.
But just to challenge you on that, whilst we're confident in smoking, why are we confident in smoking and not in coffee? Because there have been no randomized controlled trials of getting people to smoke and other people not to smoke. I mean, so that's still on observational studies, is it not?
The major difference with smoking is that the effect is tremendous. We're talking, as I said, of a 20-fold increase in risk of lung cancer, 10-fold increase in cardiovascular disease. Many other diseases have tremendous increase in risk. For each single nutrient, each single things that we eat or drink, the effects, even if you take these studies literally, are much, much, much smaller. And based on what we know from some randomized trials that we have done, the effects are pretty much close to null, if not exactly null. I mean, it's very likely that they're exactly null, which means that it's a complete waste to even try to pursue them any further.
What about...
We cannot really use epidemiology to study a relative risk of 1.01. we can do it, study a relative risk of 20, which is what's the case for smoking.
And just to dissect that out for people don't know the statistics, is that 1.01 is there's no effect, 1.01 is just tiny, whereas 20, an effect of 20 is 20 times the risk. So 1.01 is just a little bit over what would be normal and probably within normal limits. So what about eating patterns? I mean, you yourself have been involved in trials of the Mediterranean diet.
So I think that eating patterns, in theory, might be able to get you a little bit of that complexity of all these nutrients interacting together. But even those are very difficult, if not impossible, to study within an observational context. Again, you have most of these problems operating. Number one, you need to ask people what type of eating pattern they're following, and responses may be accurate or very often may be very inaccurate, especially if you try to recall what you ate and tell what you're doing. Just try it to yourself and see whether that information would be reliable. The second problem is that you still have extreme complexity among all these nutrients. We have over 200,000 different foods that you can combine in different ways. There's no clear eating pattern that each one of us is following. We follow different eating patterns in different periods of our lives and different days even. And it also changes all the time. If you superimpose the way that we react to all of these chemicals that we digest, our metabolic profile, also our genetic profile might affect how we react. Circumstances, our environment, socioeconomic factors that dictate what we decide to eat or not eat, and what we do or don't do with our life at the same time. It's an extremely complex system.
That is the end of Part C. You now have 2 minutes to check your answers.